This conference will now be recorded.
Assalamu alaikum everyone. It's real pleasure and honor for me to be moderating this clinical meeting of the Ophthalmic Society of Pakistan. I welcome you all to Lahore General Hospital to attend this meeting with us. And first of all, I will start with Tilawat-e-Quran, and I am going to invite Hafiz Muhammad Jasim to recite few verses from Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم. والله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون. والله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم. والله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم. صدق الله العظीम। तर्जुमा वही अल्लाह है जिसके सिवा कोई इबादत के लायक नहीं, और वो अल्लाह है जो गैब का इल्म और गवाही का इल्म जानने वाला है, और वो बड़ा मेहरबान और निहायत रहम वाला है। वही अल्लाह है जिसके सिवा कोई इबादत के लायक नहीं, और वो बादशाह है, निहायत पाकी वाला है, सलामती देने वाला है, अमान बख्शने वाला है, हिफाजत फरमाने वाला है, इज़्ज़त देने वाला है, अज़मत देने वाला है, और वो तकब्बुर वाला है। और वो अल्लाह पाक है जो ये लोग शिर्क बयान करते हैं, और वो अल्लाह है जो बनाने वाला है, पैदा करने वाला है, हर एक को तस्वीर देने वाला है, और उसके तमाम नाम अच्छे हैं। और ज़मीन आसमान में जो कुछ है सब कुछ उसकी पाकी और तस्बीह बयान करते हैं, और वो इज़्ज़त वाला है और हिकमत वाला है। सदक़।
Jazakallah for beautiful recitation, Hafiz Muhammad Jasim. Now I'm going to invite the General Secretary of Ophthalmic Society of Pakistan to give a welcome address to the guests.
Uh, it's good afternoon, ladies and gentlemen. Uh, Basically, as a Secretary General of Ophthalmological Society of Pakistan, I have to bring few important points for the residents that I want to highlight here. Otherwise, it's just a speech. I don't want to go in that speech. The first thing is that as we came as a new cabinet of Ophthalmological Society of Pakistan, Lahore branch, what we did for the resident, that is very important for you to know. The first thing is that we hired the basic biostatistician, that is Hafiz Jasam. He's here. He is a master's in biostatistician, so you can write your articles, you can get the guidance from him, you can get the plan from him, you can discuss with him. He can guide you in each and every aspect of statistical work, even writing the article. So he is permanent employee of OSP Lahore, so you can get him anytime, anywhere. So he is on your for you to help out to have a maximum research product, because the basic logic of all the society is research. If we are not doing research, then there is no logic of conducting all these things and meeting and spending the money. A second thing important is that we have announced the research grant. So research grant may vary from 10 rupees to 4 lakh rupees. Maximum research grant is 4 lakh rupees. So any resident who want to conduct a research, get the research proposal from OSP, fill the research proposal and give it to OSP office, and then we will decide, and the amount of money that you need for the research, you can apply for that one, and that will be paid before the research. Okay. And next point for resident is that we have given the research grant for the resident for the international meetings. If a resident gets a paper accepted, it should be minimum of free paper. If he or she gets accepted paper, then we will give full grant. Full grant means from his or her home to her home back. It's include travel from home to airport, from airport airline ticket to the hotel, hotel accommodation, conference registration, food, meal, everything and back. And whatever the expenses we give, we will give even each penny. So that's for sure. And other thing is that we have started ophthalmic competition between video and photographic. Unfortunately, very few residents participated in that one. In last year's competition, it is a 3 monthly. You can submit video or photograph anytime between these 3 months. Now, for example, from January to July, January to April, we have started this new one. Any resident can present any photograph, any video to submit at OSP or to Mr. Adil, and we will put it in competition, and you will get a big prize at the end if you win on the annual meeting. As you saw this year, we gave I think we have gifted or gave the trophies and prize dozens more than any time it had happened, just to encourage the people. Even we got only two photographs for the whole year. I gave the first and second and third prize to both. So at least they participated. Those who are not participating, you should spread the message and people should participate in that one. uh, Addition to all these things, that these are for resident, there are a lot of things that we have made. The ophthalmic WhatsApp group, where we are for residents, where we are spreading out the information for all these activities. And last but not least, that these meetings, if you are not a resident in any institute, you can attend this meeting. You don't need to come. We are not pushing people to join us physically. If they are comfortable, they can work over there, and they can join online. Even you are not free during your work, you cannot join on this meeting. Whole meeting in recorded version is present on OSP website. So so knowledge has no limitations. That's our motto. So knowledge you can get even in your bed if you desire. So, and there are a lot more things. I will not take much time for these things, and you will see our performance report. So these are the few things that I wanted to highlight regarding the residents. And moreover, we named more awards for the resident in ACO and in future meetings. So that should be, bring more encouragement for the resident. And main thing for you people is to do some research work. Getting a FCPS degree and learning a cataract surgery is not worth of you. You are the one of the best people in the country that has been chosen. And not only this, Allah has chosen you to the best work to the humanity that you can do. Think about it. Leave about the merit of medical college. Just think, you have been chosen for the work where even you want or don't want, you are getting the blessings of the Allah every time, because you have been chosen for the best work. So why you think yourself that you cannot do this thing or not thing? So you have to appreciate yourself. You have to have utilize your youth, not just for an FCPS, just for not for a cataract surgery. You have a lot of do for humanity, to grow, to do the research. Research is the biggest blessing that a doctor can do. You are doing the research, you are giving a new treatment, new idea to treat the humans. When somebody is giving an idea that will treat the thousands or millions humans, you think it is less blessing than praying 7 times at the tahajjud? I think it is equal to that thing. So there are a lot more things to get the blessings of Allah, rather than only doing the 5 times praying. So you can, as a doctor, you can get a lot more from all these things. So try to understand it, because I believe that the person who has created the steroid, do you think how much big humanity services he has done for the human, whether he's a Muslim or not? But you think if he didn't have invented the steroid, now 90% have been sick moving around us. So it's a blessing for you. You should have to do more. I will not hold for long. Thank you so much for having me, and we will have a very interesting case series. Thank you so much.
Thank you very much, Professor Khakan. And I wish you all the residents to use your capabilities to the maximum. And let's start with the scientific content of our meeting. I'm going to invite the first presenter. She is Dr. Isma Noman, working as a medical officer in I Unit 1.
Bismillahirrahmanirrahim. In the name of Allah, the most beneficent and the most merciful. My name is Dr. Ismamuni Rana. I'm working as Women Medical Officer in Lahore General Hospital, I Unit 1. Today, this is a case scenario of 5 years old girl who presented in IOPD LGH in August 2020 with left upper eyelid huge swelling which was present since her birth. The swelling was causing her complete mechanical ptosis and obscuring her vision as well as cosmetic damage. Her parents described that on crying the swelling slightly increases in size as well as the reddish color of the swelling blanches on applying pressure. So here is the girl with the left upper eyelid huge mass with the reddish color. On elevating her eyelid mechanically, we would able to do her visual acuity, which was 6 by 24. It means the huge mass was causing her stimulus deprivation amblyopia. However, there was no proptosis, no ciliary congestion. Her cornea was clear, lens was phakic, vitreous was within normal limit, and there was no finding on optic disc and macula. This swelling was present for 5 years and it measured 30 into 30 millimeter in diameter, soft in consistency, reddish in color with irregular margins and irregular surface. The swelling was immobile and inseparable from skin. Patient did not complain about pain on examination and her trans illumination in bruit was negative. On Valsalva maneuver, there was mild increase in size and pulsations were present at the time of her examination. She received 3 intralesional triamcinolone injections at Multan, but her parents described that there was no significant improvement of the disease. So, after thorough examination and history, we come to the list of our differential diagnosis. Because of pulsations, it could be an arteriovenous malformation. On Valsalva maneuver, the swelling increased in size, so we could think about venous malformation as well. The swelling was present in the younger age group. Okay, so we can also think about the lymphatic malformation. However, there was no response to the triamcinolone therapy. We excluded capillary hemangioma as our diagnosis, and because of non-encapsulated swelling, it was not a cavernous hemangioma at all, as well as neurofibromatosis ruled out because it was not fulfilling the 7 criteria of neurofibromatosis, and there was no bruit. So we ruled out carotid cavernous fistula. Now we have done our investigations, which were CT scan brain and orbit with IV contrast, MRI brain and orbit with IV contrast, and to see the vasculature supply of the tumor, we did her digital subtraction angiography. This is the CT scan brain and orbit showing axial view with left huge upper eyelid swelling, which is extending from antral to posterior of the orbit as well as lateral. Okay? And this swelling is also is extending medial to the nasal bridge. This is the DSA of the patient showing vascularization of the tumor from one of the major vessels. So we reached to our provisional diagnosis as it is an arteriovenous malformation. And with the help of our worthy professor, Dr. Umair Rashid, we were able to achieve preoperative tumor embolization with expansile polyvinyl alcohol particles. There could be other options or recent advances like gelatin sponge, microspheres, microfluidics, or tissue engineering. But currently, these options are not available in Pakistan, so we did PVA particles for the embolization therapy. After successful embolization therapy, we were able to achieve the primary surgical excision plan. And unfortunately, we encountered per of bleeding, but still there was no need of transfusion at that time. 1 year later, in 2021, after the first excision as well as amblyopia therapy, that is to patch the healthy eye 2 hourly on daily basis, we could achieve her visual acuity improvement from 6 by 24 to 6 by 6. After 1 year, this is the picture of the patient showing now the tumor is excised maximally, its cosmesis is better, and she can see properly with her eye, and her visual acuity is also improved. Still, this was the first picture at the time of presentation and after her first surgical resection. Still, this needs more cosmetic improvement. So we did her DSA again and re-embolized the tumor with PVR particles in 2022 and planned her second surgical resection with skin grafting. We started the surgery with lid crease incision and extended it medially. We tried to remove the tumor, saving the skin, but it was tightly tethered to the skin. So we removed the skin as well, saving the patient's vital. And this is the defect at the time of surgery. We measured we measured the skin graft, and we took it from upper arm medially and stitched the graft on the upper leg. After 15 days, this is the post-op picture. First picture is after 15 days, and this is after 2 months. Now you can see that the patient can open her eye as well as close her eye properly, and this is with better cosmesis and visual acuity 6 by 6 achieved. It was all the effort. It was all the effort of combined departments from neuroradiology, our eye department, as well as anesthesia team, to provide the patient with best care. However, certain post-op complications were not in that case. Graft rejection, infection, hematoma, and cicatricial ectropion could be the post-op complications, but fortunately, patient did not complain about it. In the end, her parents were very keen for her betterment and rehabilitation of upper eyelid, so they put very much effort for her. So we should give her applause. Their parents जो है ना उन्होंने बहुत अच्छा जो है ना वो किया. We should pray for our parents as well. They do a lot for our care and betterment. Thank you for your patience.
Can we have questions? So, did you look for any intraocular or intracranial malformation, vascular malformation,
Yes, sir. There was no intracranial extension of the tumor.
and also intraocular?
Yes,
No
also not
fundus.
regular. So we did her fundus examination. It was within normal limit. I will mention that.
Okay.
Her CD ratio was zero point 0.2 and macula within normal limit.
Good. So, what other option do you have? You have embolized the feeder vessels
Yes,
and you have excised and applied the tube. So, is there any other option that you can do in such patients in malformation?
sir. Also no, I don't think
No,
so.
okay. So, well done. Excellent management of the case. I want to appreciate post-op picture speaks for itself. We have actually three sort of strategies to counter these malformations. First of all, so previously the nomenclature was varices, singular varix. Then there was cavernous hemangioma and lymphangioma. Now the nomenclature has been changed, and all of these are called vascular malformations. So the big category is vascular anomalies, and these have been divided into two. One is tumors like hemangioma, capillary hemangioma, and the others are vascular malformations. So instead of lymphangioma and cavernous hemangioma and varices, we now call them lymphatic malformation, arteriovenous malformation, and venous malformation. So we have three strategies. One is injection of sclerosing agents, but the recurrence is common. Embolization of the feeder vessels, that is the best technique if you can afford, and they have done it. And third is HCM with nucleotide graft. So HCM again has problems that the recurrence can occur because the underlying pathology is still there. The feeder vessels are still there. So very well done. I must appreciate.
Thank you very much, Dr. Isma, for a beautiful presentation. I must thank Brigadier Khwaja Khalid Shoaib for valuable comments and further information on this case. And I will also thank Professor Dr. Umair Rashid Chaudhry. This case wasn't possible without your help. We did the embolization with your help, and you were kind enough to see this patient, to provide you valuable expert opinion, to do the embolization of the feeder vessels, and the child did end up really with very good results. Thank you very much, sir. Our next presenter is Dr. Fatima from I Unit 2, and she is going to present on aftermath after pterygium excision. DPS ऑन हो जाता है मैं आपको टीवी पावर पॉइंट से कर देती हूँ तो ये थोड़ा सा प्रॉब्लम कर रहा है ठीक है देन मैंने मुझे इसमें भी क्लियर Assalamualaikum. My name is Dr. Fatma Khalid. I am a postgraduate trainee in the Department of Ophthalmology, Unit 2 at Lahore General Hospital. And today I'm going to be presenting a very interesting case presentation of a woman who presented to us after she had had a pterygium excision from a periphery eye care center which had gone wrong. So basically, it was a 38 years old woman who came to our OPD. She had a complaint of diplopia, and on taking her history, we found out that she had recently undergone a pterygium excision 4 months ago, after which her symptoms appeared. And on further investigating the patient and looking at her extraocular movements, there was marked restriction, medial restriction in the right eye. The extraocular movements of the left eye were within normal limits. The best corrected visual acuity of both the eyes was 6 by 9, and the interior and the posterior segment examination was normal. This is the video of us checking for the extraocular movements. And as you can see, the right eye does not go beyond the primary gaze when the patient is looking towards the left. The rest of the extraocular movements of the patient were within normal limits. अब इसी उंगली को नीचे देखें शाबाश अब इसी उंगली को नीचे देखें शाबाश इधर Then we got the MRI brain and orbit done for the patient to locate the position of the medial rectus muscle, because by then we had made our conclusion that due to the pterygium excision, accidentally, whoever the operating surgeon was, they had accidentally excised the medial rectus, but we wanted to know the position of the medial rectus muscle so that we could further go plan for the surgery. On the MRI brain plus orbit, the medial rectus was found to be attached behind the original insertion point of the muscle. Then we performed the force duction test of the patient, which was negative. The force generation test showed normal strength of the medial rectus muscle. And while we were observing the patient under topical anesthesia, we found the muscle which was attached 8 mm from the limbus, which we all know is not the normal insertion point, which that is 5.5 mm from the limbus. This is the video of the procedure. This is the force duction test, which is normal. There was no restriction in the movement. And this is the force generation test. The medial rectus showed normal strength. This was supposed to be the normal insertion point of the muscle. This is 5.5 from the limbus. And this was the insertion point of the patient. This was the muscle, the medial rectus muscle, and this is 8 mm from the limbus. We even tried to elicit the oculocardiac reflex, and the patient did show a period of bradycardia while we were holding the muscle, so we were sure that this was the medial rectus muscle. After confirming the position of the medial rectus muscle, we decided to do the squint surgery. We disinserted the medial rectus muscle from its new position and stitched it back to its normal position. This is a short clip of the surgery.
The removing a conjunctiva from the muscle was a challenge because, as you can see, the tritium excision was done with the bare sclera technique. So, and the remaining conjunctiva was very strongly adherent to the medial rectus muscle below. So, it was very difficult to take it off from the medial rectus muscle, firstly. And secondly, we were concerned that while taking the conjunctiva off, we might disinsert the muscle, causing it to slip away. ये on, अच्छा. This we passed the squint hook under the muscle and then removed as much of the conjunctiva as we could. Then we placed secure sutures on the muscle, both in the inferior and the superior position. And before cutting the muscle, we even placed the scleral sutures so that the muscle was extra secure. Then we cut the muscle and sutured the muscle back in the right position and closed the conjunctiva, which was also a bit difficult because it was deficient. The post-operative status of the patient. On the first post-op day, the medial restriction in the right eye had greatly improved, and the patient only had a slight complaint of diplopia in the extreme left case. We are currently observing the patient because we are positive that her condition will improve, and we operated on this patient 3 days ago. So she still has conjunctival swelling, due to which we can't tell what the final medial restriction of the patient will be. And in the meantime, we have recommended her to do her convergence exercises. This is the post-op picture of the patient, and this is us checking for the extraocular movements on the first post-op day. यहाँ देखें, यहाँ देखें, and you can see that the medial restriction has improved from the pre-operative state. यहाँ देखें, यहाँ यहाँ देखें, this the first picture is of the patient before the surgery, and this is the eye does not the right eye does not go beyond this point, and this is the picture of the patient after the surgery, which is showing a lot of improvement, and we are confident that it will further improve, and we are still going to observe the patient and see if she needs any further intervention. This whole case was managed by me from the examination to the surgery under the supervision of my professor, Dr. Taiba Gal. Thank you.
What would have been your management plan if you could not locate the lost muscle?
Ma'am, we could transpose the other muscles in that position. Like we could take the superior oblique tendon and put it over there, or we could have taken the superior rectus or the inferior rectus muscles and transpose them in that position. There are different methods to do that. Some of the methods take the whole tendon and we place it under the under the in the required position. And other procedures take half the tendon or half the belly of the superior rectus and inferior rectus muscles and put it in that position. Sorry? Transposition. So,
Good, very good.
thank you, sir.
The most important position is the primary position. If the patient is aligned with eyes straight, then we do not touch the eye. The second most important position is down. When you are uh, climbing downstairs or you are reading, writing. So if the patient is lying in the primary position and the down gaze, then you do not operate. We do not want alignment in any other gaze disturbing the primary position. So this human sheen and Jensen procedure for lateral rectus palsy is good if there is primary esophageal. Otherwise, we will not. Thank you.
We welcome Professor Mumtaz Hussain Saab. Thank you, sir, for joining us. And we welcome Professor Umair Rashid for guest talk. Professor Umair Rashid doesn't need any introduction. And what I can say about him that he was the man who made our dreams come true. When we were planning for intraarterial chemotherapy, everyone was talking about it in the Western world or in American world, and we didn't have the facility or we didn't have the idea that we can do. And we just went to him and we discussed him, and he did the everything. And we were the first center in Pakistan in Southeast Asia after the India who has done this intraarterial chemotherapy, and it's just because of him. So give him a big applause for his great services for him. Not only this, that because of his contribution, he is 98% of this procedure. We both are 0.1%. So he deserves more applause, and Lubna and our everyone is doing all this. And this is not just a procedure. This is the procedure that has created a massive difference between a traditional treatment of retinoblastoma and this treatment. And there is a massive difference between the outcomes and in the patient health and everything. And 90% of these cases are free of cost. So anybody, even in India, it cost Indian 1 million rupees minimum without the logistics. So here it is free. He is the person who is doing it, and we highly appreciate him for his great services for humanity. And not we are stopping not here. Because of his research, we have at least more than 10 publications on this particular topic. So we are getting the fruit that the tree that he is in plant. By we have welcomed Dr. Umair Rashid for his talk, please, sir. Sir.
Assalamu alaikum. Assalamu alaikum. Thank you for giving me a respect. In fact, it's not that difficult to do it, but there was a will and of us, and then we got away. Uh, I faced a lot of issues, not for this, the establishing the first neurointervention center in the country. No support from by the hospital, no support by the health department, but there are some people who can help us, and for that matter, in the brain we have done 16,000 cases, and about the retinoblastoma you heard about him, they have done a lot, and it's a big sport by them. And before this, my presentation, which she prepared, I was having my some test for the heart and all this, so I couldn't get a time for it. But as Brigadier Saab sharing, I just want to add in one, two things, because this Venus is nothing to do with the retino, but just prior presentations. Retino, this venous malformation, it's a very important topic, and as you people start doing it, in the same lymphadovenous procedure. When I started back in 2003, we used to give alcohol. And it has to be done under general anesthesia. You people are lucky. The blue mycin is came up and it working very good, which we are also using for meningioma now. It's American study, so it's a multiple purpose for it. Before that, Brett Service rightly said this venous malformations or arterial malformations, these are malformations. Sometimes mimic confused with the proliferative disease. It's a most important point to discriminate between the two. The second is when we do the venous sclerosing agent rates up, the blue machine needs more sessions. If done properly, the recurrence rate is day by day is decreased by multiple sessions. It can't be done in one session. And regarding lymphadovenous malformation, there was a last case which already done or not. We have to drain first the lymphatic, and then we have to put that much blue mycin in that. So it's a very sick. The other thing regarding this, the recti trapment and the surgery, imaging is very important. Still, CT scan in coronal is the best to see the rectis, believe me. And you can easily measure their depth, the width, and the locations. And for MRI, which you have shown us, unfortunately, this is without fat suppression technique. So it should be done with, you should write them to do with the fat suppression technique. So these are the points. Regarding retinoblastoma, I mean, these are the one who encouraged me to do it, and it's very fascinating. The most difficult part when they tell us day before the kid is 3 months. So I scared putting the needle in the femoral sheath, and because one or two times in over all cases we abandoned the case, and then we did after 1 week we are able to do it. Unfortunately, initially we were not having the proper disposable use for this. Once we got it, we start doing it. And when we did one or three, four cases, I had a chance to go to Hungary. There was a World Federation neurointervention meeting. It's the highest meeting. In the plenary session, you know, no one can ask the question answer, but somehow they ask anybody is interested to ask a question. तो पहले तो मैं घबराया, फिर मैं कि यार इतनी दूरों है तो पूछ लेते हैं यार, क्या फर्क पड़ता है, जलील हो जाएंगे. तो आई आज तो हाथ खड़ा तो पूरे उसमें बहुत बड़े हाल में और वर्ल्ड के फेमस लोग बैठे. मैं आई मीन एंड दैट गाय इज डन इन थाउजेंड्स इन रेटिनोब्लास्टोमा. आई सेड आई मीन which is the best place put the catheter in the ophthalmic artery? Is it in fundibulum or in the ophthalmic artery? तो हुआ ये था कि हमारे से आगे जाती नहीं थी. बड़ा इंटरेस्टिंग है. मैं इसमें बात एक और आपको यंगस्टर्स को कहूँगा, ये नीयत की बात है. हमारी नीयत ही करना है. तो ये क्वेश्चन बड़ा एक सीधी सा लगता है कि जी आगे जाना. आगे हम ये था कि आगे जा नहीं रहे थे, जितने केस किए जा नहीं रहे थे, रेड साहब जा नहीं थे. तो वो मैंने पूछा तो द गाय सेड एक्सीलेंट क्वेश्चन. आई वाज सो एक्साइटेड कि सुबह 9 बजे सुबह आने का फायदा हो गया. आई हर्ड दिस. कहता है द बेस्ट प्लेस इज टू पुट इट इन द infundibulum. No need to go to the ophthalmic artery. And for that reason, recently we had a meeting here. She discussed with the Oman guy, Jordanian guy. He has, I mean, we've done a lot of cases. Everyone is coming from Middle East and all this. And we are having, I'm
not happy with our
this is very important remarks. And that remarks gave us, I mean, more energy. Okay, we are in the right way. Because why we are having a good results? Because we remain in the infundibulum.
We had the opportunity to guide them,
Yeah.
to not advance into the ophthalmic artery where the caliber is narrower.
Right. So when we do the retinoblastoma, I mean, she has written the whole thing, which I think is not important. The only thing is practical points are important, which I could share with you, and it could help you to start it in your setup as well, because they are the mashallah, Allah has given them a chance to be a pioneer. But किसी ने start करना था, तो they are the right people. तो उसमें neuroanatomy is very important. Yesterday I was with the PIC. उन्हें भी ये कह रहा था कि यू पीपल शुड स्टार्ट ड्यूरिंग द एक्यूट स्ट्रोक सिर्फ ये कि थोड़ी सी न्यूरो एनाटॉमी क्लियर कर लें. सेम इज़ फॉर यू पीपल. मैं अभी आने से पहले ये चाह रहा था कि एक विजिटिंग फेलोशिप हो आप लोगों की, स्टे फॉर फ्यू वीक्स एंड एबल टू डू सिंपल एंजियोग्राफी or trying to reach the ophthalmic artery. You have to be specific. आपने भी international देखा, the people came very specific, even in ophthalmology. So same, we can start this sort of a thing if someone is interested under their umbrella. They could stay for a few weeks or a few days, and we can start this visiting fellowship in treating retinoblastoma. The only the thing which you know it before starting these procedures is anatomy. Because as we have all read, this ophthalmic artery is a branch of internal carotid artery, right? It's entirely wrong. It's a branch of anterior cerebral artery. Secondly, when we discuss about the middle meningeal artery, it's not a one artery, it's a system. And it could originate from ophthalmic artery, occipital artery, from anywhere. It's a system. So इस तरह के point sometime इनके tumors में हुआ है कि ophthalmic artery was obliterated by occluded by the tumor. We don't have access from there. At least we should be knowing what else we can go this. So you should be knowing the anastomosis. So we went into the maxillary artery. Many times it happened. We even went to the middle meningeal artery, reaching to that branch, and you could see the choroidal blush. ये हमेशा इंटरेस्टेड होती है जी, ब्लश दिखाएं हमें, ब्लश दिखाएं. कभी नजर आता था, कभी ऐसी कहते यही है क्या. तो वो फिर ये शर्म के बारे में पूछती भी नहीं थी, यही है. तो बट इट वर्कड. तो उसमें न्यूरो एनाटॉमी एक्सेस और बाकी ये कि विल और डिटर्मिनेशन इफ यू वांट टू डू दिस थिंग, एंड आई थिंक इट्स क्वाइट रिवार्डिंग। जब इनके कमेंट्स इनके पेशेंट से आते थे तो मुझे भी एनर्जी मिलती थी कि द फादर इज़ वेरी हैप्पी, मदर इज़ वेरी हैप्पी, उसका ट्यूमर रिग्रेस हो गया। तो इट्स अ बिग ब्रेक थ्रू फॉर अस कि वी आर एबल टू गिव सम good क्या कहते हैं एक access to the patient which are not getting this facility in Pakistan. They have to go to India or somewhere else as well. So she shown yeah, this is the we usually go from the femoral sheet, and we use the radial sheet. Sometimes is unfortunately कुछ आजकल फिर shortage हुई तो हमें femoral sheet जो है वो बड़ों की sheet से करना पड़ता है। वाकई जब होता था क्योंकि स्पेज़म में बड़ी जल्दी जाती है, तो सिर्फ जिसको बच्चों के अंदर प्रिक करना आता है दे आर द राइट पीपल टू डू इट। सो वंस यू मेड द फेमोरल शीट यू हैव टू गो ऑल दी गो वे विद द 4 French कैथीटर, ये सारी प्रेजेंट है। अंडर फ्लोरो आप जाते हो, आप इंटरनल क्रोटेट में जाते हो, ऑप्थेल्मिक। यू हैव अ वीडियो? या आई कैन। So we are trying to reach in the internal carotid artery, making a position, और पता नहीं वो केस ना लाइयो जिसमें हम ना गए हो। तो anyhow, तो they are trying to do it। इतना टाइम मेरा नहीं लगता बट लग गया। ये हम रोड मैप बना लेते हैं, इट्स वेरी इजी। द एंजियोग्राफी मशीन इज हैविंग इट्स कॉल्ड DSA, डिजिटल सबसेक्शन एंजियोग्राफी। सो वी मेक अ रोड मैप, and you could see कि वो wire or catheter, they are trying to go into that vessel. If they could able to reach it, usually it take 5-10, ये जहाँ नहीं जाना होता वहाँ चले जाते हैं फिर anyhow, but it is there। अभी मैं केस करके आया हूँ अब। यस इट इज इन द कॉमन, और उसके बाद फिर लेटरल प्रोजेक्शन होती है जिसमें यू कुड सी ये। दिस इज द लेटरल प्रोजेक्शन, and then we are injecting the contrast in the middle cerebral artery, and we are आप बोलो ना you are तो we are in the internal, पहले उसका देख लिया उसकी पूरी एंजियोग्राम एंड ऑप्थेल्मिक आर्टरी नजर आएगी तो विल गो इन। वो तो है लेकिन ऑप्थेल्मिक नहीं है इसमें। इसमें तो ये मैं जो आपको
इसकी
कह
जो
रहा हूँ ना
डायरेक्ट
कि
ब्रांच है ना वो मिडिल क्रेनियल आर्टरी ही होती है,
अपना
तो इसलिए अब इसको
शॉर्ट टर्म
इंगेज करना होगा
फेलोशिप
एंटीलेट
उसके अंदर आप CCF भी ले
ऑप्थेल्मिक
सकते
आर्टरी।
हैं। इट्स इजी टू ट्रीट, वरना तो इट्स a disaster। We just put the balloon and we did just yesterday। Otherwise, sometime you need to have to put the piles in, which we have to do it। But by and large, 60% आप CCF कर सकते हैं अगर हम विजिटिंग फेलोशिप का प्रोग्राम, और वीनस मेल्फॉर्मेशन उसमें कवर कर सकते हैं। पूरे हमारे पास रोज के जो टर्न ओवर है आते तो 4-5-6 पर डे, हमने हफ्ते में 1-2 दिन रखे हुए, तो वो भी आप लोग कर सकते। ये देखिए वी आर ट्राइंग टू गो, ये उसको जूम किए और ये वायर के साथ वी आर मेकिंग अ वे, उसको कर्व करते हैं, इसमें सीधी वायर नहीं ले जानी होती है। और ये जहाँ वायर की टिप है दिस इज कॉल्ड इनफिनिबुलम, और यूजली अगर सही प्रॉपरली जाए तो इट हार्डली टेक्स 5 मिनट्स जॉब इफ इट इज देयर। तो अगर ये नहीं होती तो देन विल गो इनटू इन द एक्सटर्नल करोटेड आर्टरी। आगे कर ये ये देखें एग्जैक्टली वी आर इन द टिप। वी नेवर ट्राई टू गो अप, मतलब पहले जाते नहीं थे, अब तो वैसे ही जब प्रोटोकॉल पता चला है कि उससे आगे नहीं जाना तो वो इट इज़ वेरी इफेक्टिव। एक उसमें 2-3 चीज़ें फ़ायदे होती हैं। एक तो रिफ्लक्स नहीं होता, वेजोस्पेजम नहीं होता, क्योंकि ऑप्थेल्मिक वेजोस्पेजम में भी जाती है जब उसको ये हाँ ये ब्लश भी आ रहा है। तो इनफेक्ट उसके बाद फिर वी जस्ट एंगेज देयर, फिर ये आई वाले दे पुट द मेडिसिन, वो आधा पौना घंटा जितना भी टाइम भी लेते हैं वो, शी इज़ द राइट लेडी टू एक्सप्लेन द होल थिंग। एक्सटर्नल क्रोटेड वाली भी वो नहीं है तो दे प्रिपेयर इट। ये कर रहे हैं जी, ये इनफेक्ट इसमें कोई इन लोगों की ज़्यादा है, बल्कि ये उल्टा कह रहे हैं 10% हमारा काम है, 90% लोगों का काम है। और सबसे बड़ा पेशेंट को कन्विंस करना बड़ी बात है। पेशेंट आ जाता है और हमारे पास तो अनफॉर्चुनेट जो पैसे दे भी सकते हैं वो भी नहीं देते, पता नहीं साड़ी शक्लें ते लिखे पैसा देना आराम है। तो anyhow, but it worked very well। I mean, I'm glad I got a chance to share my views. It's not a presentation but it's a blessing. अब इसके फेस के ऊपर इसके माँ बाप से दुआएं जो मिलेंगी इन सारों को,
This
तो
is her
उसमें हम
tumor.
लोगों का भी होगा. क्या बताएं?
This is before ISC and this is after the first ISC, the picture on the right side. Then we have the picture after the second ISC. While we were doing the third ISC, now we could not find the ophthalmic artery arising from the internal carotid artery. We had to go back to the middle meningeal artery and we approached from that side, and still we had a beautiful regression even after injecting through the external carotid artery. This is another case after first ISC, then after second ISC. This is after first ISC. What makes ISC so expensive? This is a commonly asked question, so let's have a look on the culprits. This is the micro catheter, which is the most expensive thing. This is the guide wire, the femoral sheath or the radial sheath, a
इस
cerebral catheter.
इसमें लकीली अभी मैं आपको बता दूं, कल दोबारा रिवाइव किया सेहत कार्ड, और मैं आप लोगों को भी कहूँगा कि वो डिस्पोजेबल आप अपनी लिस्ट बना के दे दें. आजकल दोबारा स्टार्ट हो जाएगा. ये जी पहले स्टार्ट होके बंद हुआ इधर, अनफॉर्चुनेट ड्यू टू सम पॉलिटिकल रीजंस, अदरवाइज कोई इश्यू नहीं था. वी हैव डन 125 केसेस, 6-6 लाख तक मिलता रहा. और अभी कल मैं आपको कल एक पेशेंट आपसे शेयर करूंगा विच कुड हेल्प अस इन फ्यूचर. सीसीएफ का पेशेंट, पोस्ट ट्रोमेटिक, उसका ह्यूज वो था कि 7 एक्सपेक्टेड तक क्वाइल पड़ेंगे. इट कॉस्ट देम, मतलब उसने जमा कराए 8 लाख, और जब प्रोसीजर हमने ख़त्म किया वो जस्ट पुट द बैलून, दैट कॉस्ट 2.5, 3, 3, 3.5 लाख. तो पता चला उसने घर भेज दिया. आई जस्ट स्टॉप द प्रोसीजर. उसको उसी वक्त का, यार ये ले पैसे सारे ले वापस कर. किसी एक को, बड़े बड़े प्यारे नेक लोगों, उसको फ़ोन किया, यार 1.5 लाख दे दे. 1.5 लाख दिया, उसके सारे पैसे वापस किए, घर उसका वापस दिलवाया. आज वो डिस्चार्ज हो जाएगा, मोस्ट प्रोबेबली इनके यूनिट में दाखिल है. तो डिस्पोजेबल इज़ अ बिग इशू, बट डिस्पोजेबल सेहत कार्ड के थ्रू हर बंदे की आ जाएगा. सिर्फ दे हैव टू राइट सम लेटर. वो आई कुड शेयर यू, क्योंकि फाइब्राइड्स में प्रिंसिपल ने भी कहा है कि एक दिन हमें भी दें फाइब्राइड्स के लिए, इसी तरह आप लोग कर लें तो एटलीस्ट फिर इजी हो जाएगा पेशेंट के लिए. बाय एंड लार्ज खर्चा कोई 1.5 से 2 लाख तक आता है, बट इट्स रिवार्डिंग. किसी के हम सेव कर सकते हैं, तो इवन वी कैन पुट इट अ फंड फॉर इट. बट ये कि मेरा ख्याल है ये आइडिया जो मैंने फ्लोट किया है, विजिटिंग फेलोशिप, आई थिंक अगर ये हो जाए तो इट्स अ गुड फॉर द यंगस्टर्स. पहले तो यही लोग खुद ही फिर रन करेंगे उधर आके. थैंक यू वेरी मच.
So better treatment options can increase patients' compliance and hence decrease late presentations and such horrible orbital retinoblastoma. Patients having only single seeing eyes did benefit well from this service provided by Professor Mayor. Thank you very much.
Now I would request Professor Mumtaz please present the bouquet to our guest speaker. उन्होंने actually जाना है, कर ready है, तो we are not
Thank you very much. इसको present की मैं हम चाहते हैं कि जरा उनसे रास्ता को आवाज हो पुरानी बातों में मैं आपको मैं सीखा ऑर्बिटल डील जो करता हूँ हम दोनों एक
इसका मतलब अभी दोनों ही जमा है.
So I'm inviting our next speaker, Dr. Ahmed Fauzan, postgraduate resident in I-Unit C, and he is going to present on clearing the 3 levels.
Assalamu alaikum and good evening, ladies and gentlemen. My name is Dr. Ahmed Fazan. I am a postgraduate resident at Ophthalmology Unit 3, Lahore General Hospital. Today, the topic of my presentation is clearing the three levels. So, it's a very interesting case. First of all, I will take you through the biodata of the patient and then we will see what three levels we had to clear. So, we had a patient, a 7 years old male who was a resident of Lahore. He presented to us with the complaint of vision loss in his right eye. The loss of vision was gradual and painless for last 1 month. My patient was a high myope having minus 25 diopters, and he underwent a right-sided encirclement with pars plana vitrectomy, endo laser, and oil 5 months ago. Similarly, he went left encirclement, pars plana vitrectomy, endo laser, and oil 4 months ago for having bilateral rhegmatogenous retinal detachment. My patient also underwent a left-sided irrigation aspiration with intraocular lens implantation 2 months ago. Now the patient presented to us. He had the visual acuity of perception of light in his right eye and the visual acuity in his left eye was 636. On applanation tonometry, the intraocular pressure was 14 on both sides. On examination of the right eye, the adnexa was found to be normal. Cornea showed band keratopathy and there was a central stromal corneal opacity. Anterior chamber had silicon oil bubble. The pupil was round, relative, and reactive to light. There was a cataractous lens, and the retina was flat with oil-filled cavity. The examination on the left side was normal. So this is the image of the patient before the procedure. Here you can see the band keratopathy as well as the anterior stromal opacity. How will you manage this case? The house is open for discussion. Anyone? Any approach that you can suggest?
Remove the oil, just give it time.
Right.
And try to remove the oil and do any laser.
Yes, sir. Any other?
Have you done it or not?
Yes, sir. Yes. Yes.
Oil is inside the mucus cavity, oil is in anterior chamber. It's just 5 months and it's a child of previous grade C that has a diet. So, and he is now getting band retinopathy with oil in anterior chamber and he has got cataract as well that we usually get in these kids. And blessing is that his good eye is doing very good. He's 636 from hand motion to the postal and this eye had a good vision. So now he will tell you the next story. So what we did, I mean my real fellow did.
So our diagnosis was a right-sided band keratopathy, silicon oil in the anterior chamber, and a cataract. Our plan was to do chemical chelation with EDTA, remove the silicon oil from the anterior chamber, and do irrigation aspiration with intraocular lens implantation for the cataract. So let's see what we did. Here you can see the surgeon is performing superficial keratectomy with 15 number blade and he is sloughing off all the epithelium. Now we are applying EDTA for chemical chelation to treat the band keratopathy and you can see the
You can see how much clear it got bigger inside. You can see it's like a crystal before and just you have deprived the epithelium and put the IDT, it's like a crystal now. Before that you couldn't see that even oil, even cataract. Now it's like a normal form.
irrigation aspiration was done and the intraocular lens was implanted. So these are the post-operative images where you can see now the band keratopathy is completely gone and only the stromal haze is left because there was long-standing silicon oil in the anterior chamber. So post-operative visual acuity has improved from perception of light to 660, which is a great success in this case. So let me tell you something about band keratopathy, which is characterized by the deposition of calcium phosphate salts in the epithelium, Bowman's membrane, and anterior stroma. The band keratopathy commonly occurs in those eyes that are exposed to chronic insult like chronic uveitis, certain toxic chemicals, long-standing silicon oil in the anterior chamber, and long-standing glaucomas. We have a lot of treatment options for band keratopathy, which include conservative management, some medical management, some surgical management. So basically, the mainstay of treatment for the band keratopathy is to observe the patient. If the patient is not having any significant symptoms, we can go on observation. But if the symptoms becomes severe, patient is complaining of mild irritation. In case of mild irritation, we can use just lubricating drops or gels. But if the irritation goes severe, it can be managed with soft bandage contact lenses or rigid gas permeable hard contact lenses. When the scope of treatment goes beyond the medical treatment, we can shift our strategy to surgical treatment, especially in cases of significant visual loss and significant patient being uncomfortable. So we have superficial keratectomy. It is the procedure of choice because of the anatomical location of the calcific deposits. This can be performed manually, as I showed you, and it can be done with or without chemical chelation. There is also an option of doing phototherapeutic keratectomy with excimer lasers. Manual superficial keratectomy we have seen, and we supplement it with EDTA chemical chelation, and it facilitates complete removal of the calcific deposits. What is EDTA? It is ethylene diamine tetraacetic acid, and this is the most commonly practiced method for the treatment of band keratopathy. In our case, we got the EDTA from a biomedical laboratory, and how we prepared? We prepared a 2% EDTA by diluting 20 milligram of it in 1 ml of normal saline, and that's how we used in our procedure. So thank you very much, and have a nice day. And
Thank you, Dr. Fazan, for a beautiful presentation. We will take your guidance in treating band keratopathy and in preparation of EDTA. It was excellent.
Actually, I was shocked when we saw Costa. And I was missing on that day in OR, and Dr. Sam Mohammed did it. And next day, I was not agree on the treatment. I was partially agree to do the EDTA, removal of the oil, usually oil comes again, and do the cataract. Three steps in a pediatric eye, having an inflamed eye and having the oil filled cavity will give a more inflammation in post-op. He said that we will do it. Let's see far off how it happens. And luckily, I was not there, so they did the all job. And the post op, I was very happy, and I said, "What you have people have done?" And then they showed me this video. That's why we presented this one. So they were happy for seeing sir, how magically you do the clear the cornea. As they just swiped it, everything was like crystal. So you can perform. So I have never done it before. EDTA was not really available. It was I did in 2007 or 8 something, a one scale, and never found
So we must
EDTA.
congratulate Dr. Hasnan Muhammad Baksh
Sam
on
Mohammed did a
good
great
achievement.
job with
Yeah.
this guy, Dr. Ahmed Fazal.
Thank you very much.
वो है अब अवेलेबल हो जाती है इस अवेलेबल बट इट्स नॉट लाइक बिफोर के वो बिल्कुल ही बंद हो गया अभी उसी में मिल जाती कोर्स हो जाता मिल जाती
This conference will now be recorded.
can be a retrobulbar tumor. So we will advise CT scan, then we will narrow down the procedure.
Yes, sir. You're right, sir. So let's have a look at the list of differential diagnosis that we considered. It could be orbital cavernous hemangioma, as the patient is a young female. There could be vascular malformations. We would need, as sir pointed out, we would need it out. Mucormycosis, as the although the patient has no comorbidity, but still it cannot be ruled out, as we know that malnutrition is very prevalent in this region, and it is a big risk factor for mucormycosis. Lymphoma is less likely, but because the patient is young, and considering the location and direction of proptosis, like it could be lacrimal gland tumor. Let's have a look at some radiology slides. As you can see in these sagittal sections of MRI, there's a huge mass present superiorly and in superior orbit, and it is extending to the retroorbital region. And laterally, there is no view of any normal orbital structure, and it is iso-intense with the brain parenchyma. And these are some axial sections. As you can see, the mass is present laterally, and it is also extending superiorly and covering the eyeball from the superior side. The radiologist reported the MRI and said that right orbital soft tissue mass arising in the lacrimal region with significant mass effect and intraconal extension. So we reached a provisional diagnosis of lacrimal gland tumor. Because of the location and direction of the proptosis, it seemed like the most likely diagnosis. The management plan of this patient was finalized excision biopsy via superior orbitotomy through extended lid crease incision. Let's have a look at the surgery. These are the pre-op pictures of the patient. Here, the surgery was done by our worthy Professor Muhammad Moin Saab. I had the honor of assisting the surgery. As you can see, he is dissecting through the layers of the upper eyelid. Here he has elevated the periosteum. Now we have reached the mass. As you can see, it's a solid mass. We made a small video of excision. As you can see, it's a huge solid mass. He used a Fison retractor to get rid of some connective tissue adhesions. As you can notice, just as the tumor is excised, the proptosis has dramatically decreased, or we can say it has almost disappeared. Here's a close-up shot of the tumor. We sent it to a well-reputable histopathology lab in Lahore. Here is a post-op picture of the patient. As you can see, the proptosis has almost disappeared in this patient. Now, here things get a little interesting, because when we excise the tumor, the go-to lacrimal tumors that we encounter on daily basis are like adenocystic carcinoma or pleomorphic adenoma, and there are others. But I will read out the report. Malignant neoplasm with lobular architecture of basaloid cells showing peripheral palisating and clefting. The diagnosis given by Shaukat Khanum laboratory was basal cell adenocarcinoma of the lacrimal gland. Now we don't hear that very oftenly. So we had to call them and review their report, and they stood by their diagnosis that this is a basal cell adenocarcinoma of the lacrimal gland. So we had to look at the literature to find whether it is possible, and there have been some cases reported by where the diagnosis of basal cell adenocarcinoma of the lacrimal gland was made. I have quoted one of the research, Murad Khalid and others at the Montreal General Hospital, McGill University Health Center, Quebec, Canada, published a case report of basal cell adenocarcinoma of lacrimal gland in 2017. The purpose of this report was basal cell adenocarcinoma should be included in the differential diagnosis of lacrimal gland tumors. Basal cell adenocarcinomas of the salivary glands are considered of low-grade malignancy. They are infiltrative, locally destructive, and tend to recur, but only occasionally, metastasize to lymph nodes and lungs. Surgical treatment with margins of healthy tissue to ensure complete removal is considered the appropriate treatment. Luckily, this is what we did in our patient, but we are monitoring her, and we have also arranged an oncology consult for this patient. Any questions from the audience? Thank you.
It is really a large map which has been removed and cosmetic improvement is very possible. But I would like to emphasize here that never believe 100% in histopathology because they have also limitations. So in such cases, when you are doubtful about the diagnosis, ask the patient to get a second opinion from any other histopathologist. The histopathology department usually has prepared a few slides, so they can spare a few slides which can be sent to another histopathologist and take. Because I have encountered many a times that the diagnosis was changed. So always keep this thing also in mind. Young patient, 20 years, and well encapsulated, well delineated mass, and the diagnosis is carcinoma. So you have all the rights to disagree. So get a second opinion.
Dr. Fahad, if you have any experience about these cases, share.
I will agree with Khalid. ज़्यादातर यही है कि अगर ये एडिनोकार्सिनोमा होता तो इसे इंप्लीमेंट करना चाहिए।
ये नहीं
किया, लेकिन सरप्राइजिंगली मैं कंट्री भी करूँगा, इसलिए कि कुछ केसेस जो मैंने भी किए थे और उनको रीकन्फर्म भी कराया था। हमारा रीकन्फर्मेशन ये होता था कि हम जुताई शौकत खानम और आगा खान तीनों सेपरेट कराते
एक ही सैंपल करते,
एक ही सैंपल वो एक तरफ से सारी प्रोसेस करा दी, फिर उनकी प्लेट्स जो है ना हमने रिव्यू कराई, तो उसमें यही था कि
did you found ambiguity between the histopathological analysis?
हाँ जी, वो शौकत खानम में कुछ ambiguity हमें एक दो सैंपल्स में मिली, लेकिन उसमें यही था कि जब हमने आगा खान कराया है और जुताई कराया तो फिर हमें वो उसमें आ गया, वो सर्कल ही नहीं पा। ठीक है, एडिनोकार्सिनोमा जो है ना हम यही समझ रहे थे कि ये इन्वेसिव होगा या वो एक ऐसे ही केस में जैसे ये आया है, तो सर ने मुझे कहा कि बोन होगी ये होगा, तो मैंने कहा सर इतना बड़ा मास है, तो मैंने भी उसको यूं स्कूप किया फिंगर को सारा जो है ना ऐसे था कि जैसे पहले ही डाइसेक्टेड है, वो फिंगर डाइसेक्शन से ही जैसे है वो, जैसे सर ने अभी निकाला है कि बाइसेप से ही और कोई कटिंग नहीं की, वो ऐसे ही आ गया।
चलिए अब सर की राय लेते हैं। बड़े मुमताज साहब, आप बताएं, यही केस है।
तीन लेबोरेटरी से जो आपने टेस्ट करवाया था, तीनों का डिफरेंट था या एक ही था? एक ही था। वो इसी तरह था केस, एक तो ये था और एक और था जिसमें हमारे पास ओल्ड एज एक प्रोलैप्स लैक्रिमल ग्लैंड के साथ प्रेजेंट किया था, जो कि लिड मैस की तरह जो है ना वो प्रेजेंट कर रहा था। तो उसमें हमारे पास यही था कि लेकिन जब उसको हमने रिवर्ट की तो हमें जो है ना ग्रैनुलर स्ट्रक्चर जो है वो नॉर्मल है, लेकिन वो भी बड़ा एनकैप्सुलेटेड था। उसको हमने दो गिनी आगा खान और जो है ना उससे जुताई दो से कराया, शौकत खानम को हमने शूट किया, वो भी एडिनोसिस्टिक निकला, लेकिन दैट वाज 1 सेंटीमीटर और वो भी एक केस जो है ना वो पहले प्रेजेंट होता है।
चलो तो इन सारे केसों को इकट्ठा करो, इसको पेपर लिखो बस 2 महीने बाद जब सारे मिलो, 2-4 केस उसके पास है, एक आपके पास है, 5 है, 2 केस और लो, 7 केस की केस सीरीज बनाओ, और जो अप्रैल वाली ईद के बाद क्लिनिकल मीटिंग उसमें बताना कि किस जर्नल में आपने सेंड किया। दैट्स द टास्क। नेक्स्ट
Thank you very much. And the literature agrees with all of you. The basal variant of adenocarcinoma looks more like a benign lesion and it has less chances of invasion. Our fifth presenter is Dr. Mehtab, working as postgraduate resident in our Unit 2, and he is going to present on peripheral constriction of visual fields in a 60 years old lady.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Mahtab Haider. I am postgraduate resident of ophthalmology, I Unit 2, Lahore General Hospital, Lahore. Today I am going to share an interesting case of peripheral constriction of visual field in a 60-year-old lady. A 60-year-old diabetic and hypertensive lady presented in our OPD last year with a history of gradual constriction of peripheral vision in both eyes from last 16 years. And that was not associated with any pain, redness, or any other ocular symptom. There was no history of trauma, acute blood loss, Raynaud phenomena, or any other significant family history. Her past ocular history dated back to 2006 when she developed gradual onset of peripheral visual field constriction. She had trabeculectomy done in the left eye. There was no record of intraocular pressure, visual fields, or other investigations. She was using timolol, travoprost, and brimonidine in the right eye off and on since then. She, this is the record of her multiple visits, uh, 2014, 16, 17, 19. In all her visits, best corrected visual acuity, intraocular pressure, and CD ratio were within normal limits, but her visual field analysis showed peripheral visual field defects which were increasing in size and density from 2014 to 2019. This is the visual field analysis of 2014, significant reduction in peripheral vision in both eyes. OCT RNFL was done at that time, which was unremarkable. This is the visual field analysis of 2016, which showed increase in size and density of peripheral visual field defects as compared to 2014. And this is the OCT RNFL of the patient, which was done in 2016, which was not significant. In 2017, MRI was advised by some ophthalmologists as findings were not consistent with glaucoma, and MRI suggested possibility of underlying small vessel disease, and clinical correlation was recommended, but there was not clinical findings were not related with the small vessel disease. Uh, Last year in 2022, this patient presented to us with further constriction of visual field. Her examination findings were best corrected visual acuity was 6 by 9 in right eye and 6 by 18 in the left eye. Applanation tonometry was done. Her intraocular pressure was 16 and 18 in the right and left eye. On gonioscopy, all angles were of grade 3. Her detailed fundus examination was done. There were peripheral circular patches of chorioretinal degeneration which were not mentioned in her previous record. The patches had scalloped border at the junction of healthy and diseased retina, and these patches had RPE hyperpigmentation. There was no peripapillary atrophy, and this slide shows sharply demarcated autofluorescent lesions. Uh, this slide shows comparison of visual field analysis of both eyes in 2016 and 2019, and the comparison shows increase in size, density, and severity of visual field defects which increased over the period of these 3 years. And in 2022, visual field analysis showed further deterioration of peripheral visual field defects. These are the differential diagnoses of constriction of peripheral visual field, leaving a small residual central field. We will rule out these differential diagnoses one by one. First of all, glaucoma. It was not glaucoma because peripheral visual field constriction did not correspond with cup to disc ratio and IOP remaining in the low teens. There was no peripapillary atrophy or splinter shaped hemorrhages. It was not retinitis pigmentosa because there were no bony specules, waxy disc pallor, or arteriolar attenuation. There was no history of PRP or cryotherapy. CRAO, central retinal artery occlusion, was out of question, and MRI was normal. There was no history of taking such medications such as phenothiazines. History and examination were not suggestive of vitamin A deficiency, and ring melanoma was not clinically suggestive. And history and examination were not suggestive of autoimmune associated retinopathy. Now we will come to the gyrate atrophy. Peripheral visual field constriction in gyrate atrophy is caused by damage to photoreceptors by direct toxicity from hyperornithinemia. Damage to retinal pigment epithelial cells and inability of retinal pigment epithelial cells to provide normal nutrition to photoreceptors. As I already told you, there were peripheral circular patches of chorioretinal degeneration, which we saw on detailed fundus examination. So this case was diagnosed as gyrate atrophy. In her management, she was advised low protein and arginine restricted diet, and vitamin B6 supplementation was given. So the take-home message is a detailed history and complete examination is a must before sophisticated investigation, so that we can save patient from mismanagement and cost of unnecessary investigations. Thank you so much. Any questions?
Thank you very much, Dr. Mehta, for pointing out the importance of accurate diagnosis. Gyrate atrophy did not require that anti-glaucoma drugs which she was used to take previously. Now I'm going to invite Dr. Usman to present as the sixth presenter in our session.
Good afternoon, everyone. I am Dr. Usman Mumtaz, postgraduate resident, Eye Unit 3, LGH, Lahore. Today, the title of my case is Lift the Draught and Refix All. So, we had a 58 years old male, resident of Lahore and teacher by profession, presented with the complaint of decrease in vision in the left eye for 6 months. But the history continued from last 12 months, where the decrease in the left eye vision was gradual, progressive, and painless, for which the diagnosis of cataract was made and cataract surgery was performed. But surprisingly, the symptoms they got worse after the cataract surgery, and now the symptoms were sudden, static, and painless decrease in vision. His left eye was the only eye since his right eye was lost to a trauma. His systemic examinations were normal, and he belonged to a poor socio-economical status. On examination of the left eye, the vein was PL and PR positive, extraocular movement was full, and intraocular pressure was 10 mmHg. His lid and adnexa were normal, so was the conjunctiva. Cornea had limbal sutures, anterior chamber was deep, pupil was round and reactive, but he was aphakic. The fundus findings showed drop rigid IOL with rhegmatogenous retinal detachment and PVR grade C. Investigations were done to confirm the diagnosis, and that diagnosis was confirmed. Now, let us see what are the predisposing factors for such conditions. The predisposing factors included surgical complications, previous surgeries, trauma, pseudoexfoliations, Ehlers-Danlos syndrome, long axial length, and after YAG capsulotomy. Now, these are the preoperative fundus images. You can see rigid IOL. And the surprise was this IOL was entangled into the retina, and that had led to the rhegmatogenous retinal detachment. Now, the surgical plan was made, which was 23 gauge pars plana vitrectomy, removal of dropped IOL, and fixation of the same IOL after PBR peel and oil. Now, this is the surgical step for scleral fixation according to Yamana's technique, and slight modifications were made in the surgical steps. Now, you can see the video. Here you can see the vitrectomy is being performed. The IOL was entangled and was taken out from the retina, and it was pushed into the anterior chamber, and now it was taken out for the scleral fixation. Proline 60 stitches were applied to the haptics, and with the help of 27 gauge needle, the tunnel was made 2 mm away from the limbus. Now you can see the IOL is now ready to be implanted again. Now the tunnel is being made with 27 gauge needle. The Proline 60 stitches are passed through the tunnel, and the same procedure as you can see on this side was done on the opposite side so that the IOL can be centered. And after the IOL was positioned, the edges of proline were cauterized so that a bulb can be created, and that can create attraction so that the IOL cannot be decentered again. After which the PVR peel is being done. You can see it was a thick band, so after which the laser was applied and oil was injected. On first post-operative day, the follow-up was made on the next day, and on first post-operative day, the conjunctiva showed congestion. There was corneal striation of grade 2. AC activity was there. Grade 2, IOL was centered, and retina was flat. On 7th day, his best corrected VN improved to 624 from PL positive. IOL was in place, centered, and retina was attached.
नहीं ये वाला वायर में चेक करो वायर वायर ये इंटरनेट वायर वगैरह का चेक करें नहीं ये इंटरनेट इंटरनेट भी चेक इंटरनेट डिस्कनेक्ट करके इसको डायरेक्ट स्विच ऑन करो इसको डिस्कनेक्ट करके दोबारा चलो डिस्कनेक्ट करके रिजेक्ट करो आगे
Right. Now, these are the post-operative images you can see, and this is the post-operative image of the AC and the whole of the eye. Any questions? Thank you.
Thank you very much, Dr. Usman. He did really lift it up and fixed it all.
The thing really is when you fill the eye to 80%, then you cannot get intraocular pressure more than 40, whatever you do. The concept of filling the eye completely with the oil is died down. Gone, it's a past. Now no one is not going to fill the eye completely with the silicone because there is no need. So you just have to portion and get the 80% filled eye, and that what happens that it doesn't give high intraocular pressure. It doesn't give any inflammatory malformation. Easy to remove, little bit quantity. We need just a bubble. The concept of filling the eye whole with the oil and then it will attach is died down. It's no more there. That's why we don't fill 100%. We go to the 80% attach to enough for any retinal detachment. And in primary retinal detachment, we have almost more than 90% success rate. We don't get any issue in these cases.
Good morning. Thank you for the invitation.
Yes. Now we have our last talk, which is about blepharoplasty. Blepharoplasty is a common surgical procedure in the West, but it is considered a cosmetic surgery, and maybe you are seeing less of it in our country. So let's benefit from the experience of people who are doing it.
Good morning. Thank you for the invitation to speak this morning. My name is Amina Malik, and I am the Director of Oculoplastic Surgery here in Houston, Texas at Methodist Hospital, and I'm excited to speak with you about the pros and pitfalls of blepharoplasty. So we all know that the eyes are really a focal part of our Good morning. Thank you for the our energy level, our overall level of alertness, as well as our perceived age. And when done properly, periocular surgery really has the impact to improve our patients' lives, both by helping their peripheral vision and their overall confidence and happiness levels. And eyelid surgery has become the third most common plastic surgery around the world, especially in this era of mask wearing, where our eyes are more exposed than ever. But conversely, when done incorrectly, upper and lower eyelid blepharoplasty really has the potential to destroy and devastate our patients' lives, and we'll show some examples of that today. And I think it's important for us to remember the first oath that we take here in medical school on our first day of med school, of primum non nocere. Sorry, I think this is moving on its own, which is, of course, to first do no harm. So I think it's always important for us to take a step back with every patient encounter we have to make sure there's nothing we're doing that could potentially harm or hurt our patients, and that we're only trying to help them. So what are some of the reasons that patients who undergo blepharoplasty suffer complications? First, it can be a lack of an effective communication. And to me, this can be a red flag that we're talking about. Second, it can be an improper preoperative evaluation. That's where it's important for us to look for red signs on the exam, which we'll talk about in more detail. Third, it's a lack of understanding and respect for delicate eyelid anatomy. You know, the eyelid anatomy is quite complex, so before undertaking any type of surgery around the eyes, it's really important to have a solid knowledge of the anatomy. Fourth, cookie cutter techniques. Each patient individual and their anatomy is unique, and it's important to tailor surgery towards that patient rather than doing the exact same approach on every patient, because sooner or not, then you're going to end up with a complication in those situations where you're doing the same surgery for every patient. And then lastly, overly aggressive surgery. You know, there used to be a trend towards aggressive fat removal, aggressive skin removal, but we've seen and learned that that can actually make patients worse off. So it's important not to be overly aggressive. So what are some of the red flags that we should think about on every patient encounter that we have before undergoing blepharoplasty? First is the unhappy patient. You just kind of get a sense for those people who, no matter what you do or offer them, just aren't going to be happy. Second are patients who have unrealistic expectations. Patients who are in their 60s or 70s and bringing you in pictures of patients or models in their 20s who they want to look like, you know, that's a red sign that this patient is looking for something you probably can't provide. Third is the history of doctor shopping. You know, if this patient has been in every other oculoplastic surgeon's office in town and they end up in your chair, that's a sign that maybe this patient is seeking, again, something unrealistic. And lastly, when patients have had several previous cosmetic surgeries, that can also be a sign of perhaps some underlying body dysmorphic disorder or patient seeking happiness, but really through surgery in a way that really can't be delivered. So I think it's really important to really pay attention to not just what we're seeing on exam, but some of these other patient factors that are important to consider when undergoing surgery. And a lot of this can be learned with time and experience, and you just kind of get a feel for this. And so it's important to trust your instincts when it comes to this. So what are some of the common complications that can develop after blepharoplasty? This is a list of just some of the potential complications, and we'll talk about these a little bit more in detail. This includes dry eye, epiphora or tearing, exposure of keratopathy and lag ophthalmos, chemosis, scarring, and ectropion, eyelid retraction, diplopia, and luckily the least common but most devastating is blindness. So dry eye and epiphora, we know, can go together. Here's the clinical photograph of severe diffuse corneal staining, and we know that patients who have overly aggressive blepharoplasty can have increased risk of dryness afterwards due to often lag ophthalmos or inability to close the eye, as well as reduced blink function when the auricularis muscle is resected. Here's an example of a patient who underwent outside blepharoplasty here in Houston and came to me with complaints of dryness and irritation in the left eye. He was a dentist and severely bothered, and you can see that he has 2 millimeters of lag ophthalmos that correlated with really severe dryness. So, and this was due to overly aggressive skin removal, as on that upper lid he only had about 14 millimeters of skin. And so it's important to ask about our patients whether they have a history of dry eyes or blepharitis prior to undergoing a blepharoplasty. You know, do they use lubricating drugs? And if so, how often? If they're using it every few hours, that could mean they have dry eye that's severe and not well suited for blepharoplasty. If they have burning or foreign body sensations in their eyes, if they have redness, corneal staining, eye fluorescein every patient prior to blepharoplasty to make sure their corneal surface is healthy before undergoing this type of elective surgery. Blepharitis, of course, the common signs including scurf in the lashes, eyelid redness or irregularity of their margins, history of cataract or refractive surgery. We know these patients are at higher risk for developing dryness, so it's important to ask about this. And then to look, of course, for any lag ophthalmos, the inability to close the eye, that this will also predispose them to worse dryness, or poor Bell's phenomenon, inability to look up, for the eye to move upwards when they close their eye. And patients who have Graves' disease, we know, have higher rates of dry eye, so it's important to look for this as well when examining our patients. As you can see in these patients with bilateral, well, unilateral at the top and bilateral proptosis at the bottom with the lid retraction. So how do we treat dry eye if our patients do end up developing this after blepharoplasty? Well, lubrication, of course, is key. We also might want to consider prescription drops, such as cyclosporin twice a day to increase the tear production, autologous serum drops, punctal plug, and I very carefully measure using both a caliper as well as a pinch technique where I pinch the skin I plan on removing prior to doing the surgery to ensure there's no lag ophthalmos that develops with skin removal. And it's important to remember you need about 18 to 20 millimeters of skin remaining for the eye to close. So the typical upper lid crease is going to be anywhere from 8 to 10 millimeters from the lid margin. And so you want to leave behind 18 to 22. So that's if you're marking 8 millimeters from the lid margin, if you want to leave 18 millimeters of skin, then you can make a superior mark from the eyebrow about a centimeter down, and you should be okay in this situation. Here's a video I can show of my typical marking, again, where you want to go right in the lid crease, typically at about 8 millimeters. here, and you go from medial to lateral. I somewhat tailor the mark superiorly at the lateral end to help the incision to be well concealed, and then from the brow, mark a centimeter, and then connecting the lines. And then once we make the mark, it's important to do a pinch with that forceps to ensure that there is no lag ophthalmos once that amount of skin is removed. And there you can see the incision is hiding the crease. So when she opens her eye, you don't see the incision. So in addition to careful marking of the skin to remove, you also want to be careful during closure to only incorporate the skin and not the septum, because we know if we're incorporating some of the deeper tissue, that can lead to contraction of the lid and inability of the eye to close. So skin only closure is important. So supposing your patient does develop lag ophthalmos after blepharoplasty, what can we do? So aggressive lubrication, of course, for the cornea. Downward massage can be useful in the early stages when the scar tissue is still forming. So just manually having them massage the lid down. 5-fluorouracil, which is a chemotherapy agent, as well as Kenalog, which is steroid, can be injected into the scar tissue to see if that releases some of the tightness and helps with the lag ophthalmos. And then lastly, in severe cases, you might need to undergo skin graft. In common places we take skin for the eyelid would include the preauricular, postauricular, preclavicular, and upper arm areas, because these areas tend to match the eyelid skin well, as they're thin and hairless, which is the goal when doing a skin graft. Now we talked about dryness, exposure, and lag ophthalmos. Chemosis is another complication of lower lid blepharoplasty, which can be quite difficult and challenging for patients. So on the top is a patient who underwent quad upper and lower lid blepharoplasty with a local plastic surgeon, and you can see had marked lower lid chemosis and rejection, which was very bothersome. This was a month after surgery, and he had attempted a few lateral tightenings with the plastic surgeon, but as you can see, it was still quite severe. And inferiorly is another patient who had outside lower lid surgery with marked chemosis. And so why does chemosis develop? So a lot of it is related to exposure and dryness from the conjunctival surface rubbing on the eye. Lag ophthalmos, again, from exposure, it just leads to irritation of the conjunctival with a related edema or fluid collection. And in extensive transconjunctival dissection,
So as we are running short of time, if anyone is interested, I can play the full video, but in case. पाँच मिनट और रखनी
can also contribute. So if you're doing a transconjunctival approach to a lower lid blepharoplasty, it's important to minimize the amount of trauma or manipulation on the tissues. And I do a closure with just one interrupted overloaded, minimal dissection. I do a frost suture on all of my lower lid blepharoplasties with the Orosilk adhered to the forehead. You also can consider patching at night, doing lubricating drops, steroid drops to help absorb some of the fluid. Tarsorrhapy can also be considered as a temporizing measure for the week after surgery. These are lubricating drops. Here's a picture of a temporary tarsorrhapy. And here was that patient I showed initially. So ectropion and eyelid retraction of the lower lid is also another dreaded complication of lower lid blepharoplasty. This is a orthopedic surgeon in town who had undergone a outside aggressive lower lid blepharoplasty. He was very bothered by his lower lid retraction, inferior scleral show that you can see here. So this, when it happens, can be really aesthetically unacceptable for patients who are going in for surgery to try to make them, look better. In addition, it can be really irritating for patients. The exposure symptoms can be significant, and it can cause a lot of psychosocial stress. And why does this happen? So it's really a multifactorial problem related to lateral canthal laxity that might not have been addressed properly at the time of surgery, middle lamellar scarring that can happen during surgery, causing the lid to pull down, as well as malar descent. We'll talk about that a little bit more in detail. So I think it's really important to remember the eyelid structural support. So there's a tensile support and there's a bolster support, and you want to keep this in mind anytime you're doing lower lid surgery. So what is the tensile support we're referring to? So this includes the tarsoligamentous length, which is composed of the tarsal plate as well as the medial and lateral canthal tendons. And we also have the orbicularis oculi muscle, which surrounds the eye and of course is responsible for closing the eye and it pulls the lower lid up the eye. So that's the tensile support of the lid. And then we also have the bolster support of the lid. And we want to address both of these when we're doing surgery. So for the tensile support, we want to make sure that the ligament is tight, the lateral canthal tendon. We want to make sure that's tight during surgery if they have any pre-existing laxity. And when you go transconjunctivally and cut through the orbicularis, there is a risk of damage that can lead to lower lid retraction from denervation. Now, the bolster support includes the malar soft tissue, so the malar fat pad, as well as the lower eyelid fat pads, of which we know there are 3. And so when we do overexuberant surgery and fat removal, this can actually worsen retraction because you're taking away the support system for the lower lid. And when you do dynamic studies of the eye, to listen to your patients, to look for some of the red flags and red signs on exam we talked about. Often less is more when it comes to eyelid surgery. You can always avoid some of these complications. And particularly remembering the full-time tensile support of the lower lid, and always incorporate a pattern of checks in your preoperative evaluation to avoid any potential. Go back and do more, but once you've done too much, it's a much harder problem to treat. Know and take some time to understand and respect the eyelid anatomy, as it really is quite complex, and having an understanding of this can avoid some of these complications. And particularly remembering the tensile support of the lower lid, and always incorporate a pattern of
Thank you all
checks in
very
your
much for your
preoperative
patient
evaluation
listening.
to avoid
And now
these
it
potential
is the most awaited session.
do your blepharoplasty.
It's about price
Thank you so
distribution.
much for your attention. This is a picture of me and my 3 children, and
Thank you, Ji. So we are reaching to our results, and I will request Dr. Devakul to accompany me here, and I will request Ashish please come, and third position. We will start from the third one. So no heartbreaking. So the third position is tight, and it goes to the 2 people. It's Dr. Usman Mumtaz and Dr. Fatima Khalid. Yes. Come in the center. ये Usman से Fatima पहले देखिए Usman इधर देखना बेटा उधर ठीक है ये एक मिनट ये आपके लिए पार्टनर का पेन ठीक है जब उधर देखना है हाँ जी अच्छा सर प्लीज this is the thing that you have to learn, because when you are presenting or getting something you have to face the camera and to get the prize. This is also the one step after the presentation. So this is the learning. Okay, thank you so much. Please, Usman. Meditate and over there. Now I will request Alishwar sir, please come here. And can I have a silence, please? Hello. So our second position holder is yes, Dr. Ahmed Fazan, our professor. My name is my professor Ahmed here. Udhar dekhna samne se. Pen, yes. So this is your pen here. Done. Thank you. Done. And the first position goes to Dr. Khudabaksh. Dr. Khudabaksh, please. And I will request Professor Mumtaz, please. Thank you. Very well done. Now I will request Professor Taimakul to present the bouquet to Professor Mumtaz. Sir, please guide. Center. जवेन मत कबाब में नहीं इसको देना होता है उसकी तरफ ऐसे करते हैं पता चले कौन किसको दे at the end we will no heartbreaking and everyone did a good job so it is just a competitive environment we have created that next time you get the encouragement no one is not winning no one is not losing. So everyone gets his own chunk and everyone should know what are the mistakes where he or she is lacking. So that should be improved next time. There's a lot of stadium and there's a lot of grounds are waiting for you in the future. Like it's just a mini stadium where you are presented and there's the international arena that's waiting for you. I will request Dr. Amina Malik to go and the Dean brothers to go and Dr. Mehtab Heather. Dr. Mehtab Heather, please. Please come up. So we will present. So Mehta, very well done. So it's just a day, and next day is yours.
Every day is
So now I will request Dr. Javed Malik sir, please come here and present Dr. Isma Noman. Dr. Isma, please. Very well done. She was the first one and she was the opener of the session, so I highly appreciate it. Thank you. We will not forget our sponsors. They did a great job for the organizing this meeting, and without them, we are nowhere on that. So I request the key brother representative to come and get a certificate from. Thank you, everyone, for joining us, and hope we learned something and we shared something. Knowledge is just because of sharing, and knowledge shouldn't have a limitation. That's the point that I am showing you all this. So knowledge you can get now in your bedroom, in your classroom, in your clinic. This is projecting all over the world. Wherever you want to know, you can learn it. So the basic motto is knowledge has no limitation, and knowledge is for everyone, everywhere where you are comfortable. Physically, virtual, sleeping. Next day, you can get all these things on the next day on our website. Whole meeting is recorded. Now I will request Professor Taibakul for vote of thanks and we will conclude the meeting.
Thank you, Dr. Hakan. It just reminds me a verse from the Holy Quran, Auzu billahi minash shaitanir rajim, Bismillahir Rahmanir Rahim. وَمَن يُؤْتِ الْحِكْمَةَ فَقَدْ أُوتِيَ خَيْرًا كَثِيرًا कि जिसको हिकमत और दानाई अता की गई उसको खैर कसीर मिल गया सदक़ल्लाहुल अज़ीम. On behalf of Ophthalmology Department of Lahore General Hospital, our head of the department, Professor Moeen, we missed him very a lot.
myself, Professor Tayyaba and Professor Khakan, I thank you all for joining us. And it is, I also thank Professor Mumtaz, Professor Ashad, Professor Khaja, Khalid Shoaib, Ali, and all of you for coming here and making this event a successful event. I also want to congratulate the OSP Lahore Center, which is progressing day by day by leaps and bounds. And it is definitely not only a few people's task, it is definitely the success of all of OSP Lahore, all the members of the OSP, and all of you. क्योंकि फर्द कायम रब्ते मिल्लत से है तन्हा कुछ नहीं मौज है दरिया में बैरूने दरिया कुछ नहीं थैंक यू सो मच
From the electronic media, CD42, and they are here and they have recorded the clinical meeting events and they will display it in their live show or somewhere in the evening and in their newspaper. So we are highly thankful the Jodi sir and his team that is been here, Adnan, for joining us. Thank you so much, Adnan, and everyone for covering us. CD42 and all the their team. Thank you so much. And the next clinical meeting will be in Mughal Hospital. And the importance of next clinical meeting is that in fact we have already decided the first meeting of every year will be conducted on the day of the demise of that of Professor Sayyid Ali Haider Shaikh. So it is lucky that that day is on Saturday, 18th Feb. So it will be on 18th Feb in Mughal Eye Hospital, and it will be. We did this because every year we have different ceremonies for this prayer for him. So we decided that we can get at one position the clinical meeting that we were pioneer, that we were ambitious for doing this educational teaching, and we can pray together for him and his better path in future life. So it's 18th February in Mughal Hospital. So please join us. Thank you. Now accompany me for the lunch, and the lunch is ready. Please, sir. Thank you.